Thank you again, everyone, for joining. I just first want to go through a bit of housekeeping before we get started. The presentation portion of this session is being recorded, and the video recording will be posted to the NCCRT website following today's presentation. So if you have any colleagues that were interested and not able to join, you'll be able to share the link with them within a day or two. This is a Zoom meeting, unlike Zoom webinar, so all participants have the option to come off mute to allow for your small group discussions later in the program. So please make sure your microphone is muted until that discussion session. If you have video capabilities, we encourage you to be on camera during that group discussion. It always helps it to feel a bit more interactive and when we can see each other and get to know each other. And so that we can all start getting to know each other a little bit better, please share with us your name, where you're from, and your organization in the chat. So again, that's name, where you're calling in from, and which organization you represent. And adding that organization name either in the chat or to the right of your name by clicking on the three dots to rename yourself will allow us to be sure that we don't group you in a breakout room with your same colleagues. So if you have a chance to do that as well, that'd be helpful. So you just click the three dots near your face in the video tile, click rename, and then you can add your name, comma, and organization there. And finally, we greatly appreciate it if you take a couple minutes to complete our evaluation at the end of today's call. So with that, we'll move on to our objectives. So our goals today are to introduce the Family History and Early Age Onset Colorectal Cancer Strategic Priority Team. Our hope is that NCCRT members, Comp Cancer coalitions, other CDC grantees connect with the Strategic Priority Team and with each other. We're going to learn how Yale New Haven Health System is using the EHR to systematically identify and invite at-risk patients to participate in genetic testing for Lynch Syndrome. And another big goal is for participants to have a thoughtful discussion about potential opportunities and challenges. So if you're new to our Blue Star Conversation series, you're probably starting to get the sense that the format is a little bit different than a typical webinar. Each one of these is hosted by one of our strategic priority teams and features a short presentation followed by a small and large group discussion among attendees. So it's a great way for everyone to not only hear from our presenter, but learn and engage with our strategic priority team chairs as well as other attendees. We began offering this program because we found a need for providing our members with opportunities to discuss important topics outside of our annual meeting. And as a reminder, this series is open only to NCCRT members, CDC grantees, as well as select invited guests. We'll move on to the next slide. So today we'll engage with the Family History and Early Age Onset Strategic Priority Team. We have with us Heather Hampel is live, and she'll be taking over as moderator in a moment. Dr. Paul Schroy, unfortunately, had a conflict today, but he's an active co-chair of this group as well. We'll discuss potential opportunities and challenges in our small groups and share top takeaways. So we're excited to hear your thoughts and feedback and hope that you're geared up and ready to participate in these discussions by coming on camera and off mute following the presentation. So with that, I'm really pleased to introduce to you Heather Hampel to share a bit about the work of the Strategic Priority Team before introducing our speaker.
Thanks, Emily. Thanks, Emily. So glad to be here. So many of you are on our strategic priority team. It's the Family History and Early Age Onset of Colorectal Cancer strategic priority team. And the charge of our team is to identify key issues and areas of need around familial colorectal cancer and early onset colorectal cancer for the purpose of identifying opportunities for the NCCRT to be a catalyst for change. Our strategic priority team has been extremely active for over 10 years, always working on something exciting. We were the first to give a Blue Star Conversation talk last year. I gave one in, I guess it was 2 years ago now, in March of 22. And our turn's back up again today, so we're super excited to have Dr. Llor giving another Blue Star Conversation on the topic of family history and early onset colon cancer. We've also developed our many tools, but the one shown here is our advanced colorectal polyp GI brief, trying to help GIs to notify their patients that their relatives are at increased risk if they have an advanced colorectal polyp. We've also done the family history module, which is, what you need to take as part of a good quality colorectal cancer and polyp family history, which is some of the work that I think inspired Dr. Llor's study that he's going to talk about today. So if you're not on our strategic priority team and you want to join, see us at the annual meeting this year. So here is the risk assessment and screening toolkit I was just referring to. We did this in conjunction with Jackson Laboratory, and it aims to improve the ability of primary care physicians and other clinicians to systematically collect, document, and act on a family history of colorectal cancer and adenomatous or precancerous colon polyps. It educates clinicians on the need for timely diagnostic testing for young adults who present with symptoms of colorectal cancer. And we know not everybody has a family history. And so in addition to identifying people with a positive family history who need screened earlier and more frequently, we want to make sure that primary care clinicians are aware that if someone has symptoms of colorectal cancer, even if they're under age 50, they need to be acted on immediately and followed up to make sure they've resolved or that there's been some diagnostic resolution. So the features of this toolkit are a quick start guide because it's a rather large toolkit, and so the quick start guide can help get you started, and a sample risk assessment screening algorithm that can be used at an institution to identify high-risk patients. Next slide. And that's available on the NCCRT website for anyone who wants to use it. So our presenter today is Xavier Llor, who is a good friend of mine and a professor of medicine and director of the GI and Pancreatic Cancer Prevention Program in Digestive Diseases at Yale School of Medicine. He was a member of our strategic task group before he was tapped to co-chair another strategic work group, but he's still a member at heart and obviously does a lot of his work on family history. So we're really excited to have him today to talk to us about the program that he's implemented at Yale. Thanks for coming.
Thank you very much, Heather. It's a great pleasure to be here. And certainly it is the work of this committee that is so active, as Heather was saying, that inspired a lot of our work, because we all see that need, that we really need to identify more individuals, and we need to find the tools to make this happen. So this is what we're going to try to convince you of today. Let me see if I find the right slides here. Hold on a second. Okay. Do you see it?
Yes.
Very
Yes.
good. All right. Thank you. I do have no conflicts to disclose and no financial relationships with commercial interests. So just try to focus a little bit on the issue. About 3% of all cancers are due to known pathogenic variants in cancer predisposing genes. And of those, the big ones, we have about 0.6% of the population who are actually carriers of a BRCA mutation, so a big one, that's close to 2 million Americans. And then we have 0.36% of all individuals in the US, that's about a little bit over 1 million Americans who do have a mutation in a mismatched repair gene that causes Lynch syndrome, which, as we know, increases the risk quite considerably for colorectal and endometrial cancer, but also some other GI and other cancers, and the one that really is taking our focus here. So significant number of individuals actually that do have this syndrome. Now, how do we identify individuals to test them and to roll them out for this syndrome? And that's been one of the issues that we've been dealing with and will have to deal with for a long time. And I'm just showing the NCCN criteria here for genetic testing for Lynch syndrome. And as you can see, it's a lot of words. And I think that kind of summarizes the challenges that we face, which is quite complex. And therefore, every time that we have so many different criteria, it's very difficult to get lost and definitely remember them. So we can summarize them, though, in criteria that are based on personal and or family history of cancer. And then the other set of criteria that helps us also identify individuals is when we see evidence of mismatch repair deficiency in the tumors themselves, someone who just had a cancer. And that's quite a unique feature that we've been using for the last 15 years, recommending doing testing for mismatch repair deficiency, which in most cases is doing a simple immunohistochemistry stain of the tumor, see if the proteins that are synthesized by the mismatch repair genes actually are absent in the tumor and present in the normal tissue. So we've been recommending this for the last 15 years or so. All guidelines have been recommending that on all colorectal and endometrial cancers. And lately, we've been expanding that recommendation more towards like including all those Lynch syndrome related cancers. But the issues that in spite of that recommendation starting to be really old, we basically have seen that the implementation of that recommendation has not been that great. We've been documented here 2019 paper that less than 50% of institutions in the US were systematically doing this test, even though, again, all guidelines actually have been recommending it for years. But the other issue is that even when implemented, less than a third of individuals end up having being referred for genetic testing. So even institutions that are doing a great job at systematically doing that and identifying individuals this way, then for one reason or another, they just don't get tested. This is exactly what we saw here at Yale when we looked at all individuals who qualified because of these criteria from 2012, 2015. Basically, less than a third had been referred and got genetic testing. The others just basically did get ignored. And it's important to recognize that most pathology labs actually add a sentence at the end of the report saying, because there is this mismatch repair deficiency, you really need to rule out Lynch syndrome. And yet still, the majority of patients actually don't get referred. So that is an issue that we really need to tackle. And the other issues like the identification, again, based on past history, past personal family history of cancer. And here's a report based on US National Health Interview Survey that basically they just saw that only 8.4% of patients who qualify for testing to rule out Lynch syndrome were actually recommended testing. And finally, only 6.7% end up being tested. So pretty dismal, actually, and that is a big problem. And in this more recent paper where they looked at factors trying to figure out what's preventing us from identifying more individuals, the main issues that were recognized were this lack of awareness of guidelines by clinicians, really largely due to their complexity, that would really prevent identifying these individuals. So ways to go here, and definitely a need for different strategies to work on that. So so we started working on addressing the first issue, which was the testing of the tumors themselves, which is again widely recommended and a good opportunity. So what we did, and again looking at our dismal in-house data, what we did is we developed a system with IT and the Department of Pathology that the system actually automatically searches for all tumors that had mismatch repair assessment through immunohistochemistry and pulls all the tumors that actually had a deficiency in one of these proteins. We add other factors here I won't get into, but they help us fine-tune this. And what it does, what the system does automatically without like going through anyone, is generating a weekly list that gets sent to our Lynch syndrome clinic through the electronic health record that gives us all these medical records of individuals who had tumor testing that had a deficiency in a mismatch repair protein. For the trial period, we waited for 2 weeks. And if there was no referral placed by mostly the surgeons, then we would just seek out for referral directly through a EMR message to the, again, to the surgeons, see if they would refer these patients. So this is what we have here after, as a result of this intervention. There's, the N is 76 individuals who had tumors who had mismatched, in this case, only colorectal cancers, who had mismatch repair deficient tumors. And in those cases, what we saw is that prior to the intervention, that means without us doing anything, 50% of individuals got referred. But after the intervention, we got an additional 42% of individuals who ended up being referred. When it comes to individuals seen, pretty similar numbers here in terms of percentage of the individuals seen after being referred. And finally, Lynch syndrome diagnosis, we added 4 patients up to the 9 patients that had been recognized without the intervention. So basically, the referral rate went up to 92.11% from that baseline of 50%. Seen and tested among referred, almost 75%, and we increased the Lynch syndrome diagnosis by 50%. So really, it took a while to put the system together, but once it's put together, there's really no much effort, but just maintaining that list, making sure that things happen, and the effort is not big. And again, I think the outcomes are nice. And there's also some extra information that's useful. We wanted to see how we are doing in terms of addressing the underserved populations. Here we put together non-Hispanic whites versus the other racial and ethnic groups that we have. Here is appropriate referral top, and here is patient seen. And as we'll see here, there are no significant differences after the intervention among individuals referred. No differences between the non-Hispanic whites and the other groups. And actually, there are no significant differences in evaluation and testing among the different groups too. And basically, at the end of the day, we saw that the Lynch syndrome diagnosis almost multiplied by 3 through this intervention. And again, there were significant increase in Lynch syndrome diagnosis was seen in all different racial and ethnic groups, which we really felt it was very rewarding, particularly seeing that in our original background interventions, we were seeing very few of the underserved populations. So definitely, we've seen deficient implementation of tumor testing, and when implemented, still many patients are not being referred for testing. So it's not only that we need to get more pathologists to do that, but also we need to make sure that this is followed up. And we also need to improve mechanisms to improve this genetic testing uptake. And finally, some systematic approaches like this one may have some disproportionately positive effect on underserved populations, because actually what we think is that we're basically tackling unconscious bias. If the underserved population are benefiting more from that, it's because they were not referred as much to start with. Yet, with a reminder, that really put us at the same level as the rest of the population, which really tells us that sometimes gentle interventions may get you a long way, actually. So the other issue is, okay, well, besides that identification through tumor testing, we have the identification through family and past history of cancer. So how can we really do that? And again, this is part of those busy slide with the guidelines, and some of them here, those are based on personal history of cancer, and some of them are easier to remember. Let's say any Lynch syndrome related cancer diagnosed at an age less than 50. We want them to get tested, but others are not so easy to remember. Same thing with the family history based ones. One first degree relative with colon cancer, endometrial cancer diagnosed at an age less than 50. Maybe easy to remember. The other ones become a little bit more complicated. So it is definitely challenging because of the complexity of these guidelines, the lack of awareness of these guidelines, as we've seen documented, and lack of awareness in general of Lynch syndrome, even though, as we said, it's common enough that we have more than 1 million Americans who have it. And finally, capacity to test. We need models that can handle a significant increase in testing populations, and that's something that we need to tackle. Otherwise, we're just not going to do well. So the question we pose ourselves is, can we identify more at-risk patients, and can we use already available information in the EMR to help identify candidates for genetic testing? So move from a manual clinician-based identification to a registry-based system that after creating rules that identify patients, they end up being included in this registry that can be converted in a relational database that allows us to really tap on the information and use it for the purposes. So the way we went about to build this, this is the strategy. We used to start with our population is the Yale New Haven Health Wellness Registry. And the Wellness Registry is basically a registry of active patients in the system. And active means individuals who've been seen face-to-face within the last 3 years at the Yale New Haven Health System, either inpatient, ambulatory, ED, affiliated locations, anywhere. And they do so with all these touch points. They'll have a Yale's EPIC EHR contact again, and those will be our denominator. Testing criteria, basically, we got the NCCN for Lynch, high penetrance breast, ovarian, and pancreas, and then we use the ACMG criteria for the rare syndromes that we want to identify too. And we decided to use structured data from the EHR, so including personal family history of cancers, histology types, age of diagnosis, but all structured data, not using natural language identification, because that gives a lot of background noise. We were enabled also the use and tapping of external data. So we were able to capture basically standard interoperability information that is in the Care Everywhere system. So individuals who've seen in another institution that also uses the same medical record number, we are able to access that information, and that's pulled also for our system. The logic built ended up including 218 rules that serially evaluate all the criteria that we talked about, and if they are considered at risk, then they get selected into the at risk for the particular syndrome. The outreach was done basically for the outreach. We excluded all individuals with a cancer diagnosis and the individuals seen by cancer genetics or the Lynch Syndrome polyposis clinic, or individuals who had pending appointments with these programs. If they had already been seen or they had appointments pending, those would be excluded from the outreach. And I'm not going to get into the outreach today, and I think we'll have more opportunities to talk about the experience of outreaching. We did have limitations, some of them due to the pathology system being different from the EPIC EMR. The pathology department uses COPATH, and that does not talk very well to the system. So even though we used them for the tumor testing for mismatch repair deficiency, it was very difficult to put them into the process of this whole strategy, because that was based on EPIC and they use a different system. So picking up triple negative breast cancer, for instance, that was a bit of a challenge. And also another one is related to the limitations of EPIC, which is that the family history of cancer has a number of limited diagnoses in EPIC. So when you choose when you have your patient and you choose from the drop down the diagnosis, you can choose absolutely everything. But when you try to select cancer history from family members, there are a lot of diagnoses that are just not available. And you can see some here that are relevant to Lynch syndrome: small bowel or intestinal cancer, biliary tract, glioblast. Those you can't check, we can pick them up for family members, yet you can select them for your index patient, for the patient you're seeing. Available, these common ones, they are available. So we had some limitations that probably they're not huge numbers, but significant enough, and they are truly limitations that we need to and we are gonna try to push EPIC to really have a more completed information from that standpoint. Then we had to deal with the diagnosis list. And I don't know if you're familiar with SNOMED. This is this systematically organized, computer processable collection of terms that really provide codes and synonyms and definitions. Basically, just it's all these hundreds and hundreds of terms that often you want to pull out together under a grouper, because that's what you want. For instance, if you want a colon cancer, you have adenocarcinoma of the colon, Dukes A, Duke C. There's just all these different diagnoses, different criteria that you want to pull all together, because all you care about is an adenocarcinoma of the colon, for instance, in this case, as an example. So that's where we did spend a lot of time trying to really put together all the different groupers that would incorporate all the diagnoses that are relevant to what we're doing. So then deciding what hierarchies do we use. So that's definitely quite a bit of effort. And then after that, we just went to develop the logic statements that basically what they do is they dissect each criteria in a series of rules that evaluate the personal and family history as true or false. They calculate also the age of the personal family history according to the criteria we set it up, and categorize family relationships. A simple example here, one of the rules will be, does the patient have colorectal cancer diagnosis in the problem list or diagnosis list? And does the patient, was the patient diagnosis added before age 50? That would be 4 and 5. If you have 4 and 5, that would qualify you, for instance, for Lynch syndrome testing. So that would be, so that's what the system would do. If we have a yes here and we have a yes here, 4 and 5 constitutes a criteria, and that would be pulled, and the patient would be eligible for genetic testing to rule out Lynch syndrome. This is a bit of a summary of the initial pass among 1.6 million individuals who are active in that wellness registry. After exclusion, that's down to like close to 1,400, 1,400,000 patients. And that comes up to about 57,000 individuals that fulfill some either one of the different criteria. We divide them here between Lynch syndrome, hereditary breast and ovarian cancer syndrome, the other syndromes we talk about, paraganglioma and others. Here we do have an overlap. What we call here overlap is mostly individuals actually that fulfill HBOC criteria, but those are the ones with personal history of pancreas cancer or ovarian cancer, or first, second-degree relatives of ovarian cancer patients, first-degree relatives of patients with pancreas cancer, who really are part of this larger criteria, but also testing is recommended to include in their panel to include the Lynch syndrome genes. So anyways, that's why we had them here, because they are also relevant to our main theme today, which is Lynch syndrome. And of those individuals, we saw that these are the individuals who had already been evaluated and had either evaluated or were pending on testing, and we were left with 45,600 individuals targeted for outreach that had not been seen, or they have no pending visit for cancer genetics. So definitely a great opportunity to reach out to them. So that's about 18 to 30% of qualifying individuals who have not been evaluated. Again, a great opportunity to really increase that number. Then we went and look, it's like, how did the system do? How accurate is that? So we reviewed 549 random cases from the different criteria. And what we saw is that basically the criteria are pretty good at picking up correctly. That was 96.2% of the individuals who we evaluated were actually correctly evaluated for this criteria. The biggest source of error, in a way, of the whole system is the individuals who had already been tested and had missed. That was about 14%. What happens with these individuals? That basically whoever tested them never entered a diagnosis in a discrete field. So these patients may have a PDF in the record that has the genetic testing there, or a note may say the patient has Lynch syndrome, even can talk about the mutation, but if no one is selecting the diagnosis or problem list as this diagnosis, that's not gonna be picked up by our system. So that is an issue that, again, but we did not want to go to more wider recognition systems, because that would just get you much more noise. So anyways, those are the limitations, but the output in general is really really good. And just sharing a little bit, very brief initial information on this, comparing the wellness registry to the registry of patients that we identified through ARCAgene, to the system that we do call ARCA gene, what we see is that we have in the registry many more women, 82%, and that really reflects how the criteria are set up, particularly for BRCA with the many breast cancers. We also see that we have less percentage of individuals who are Hispanic in the registry, and we also see less individuals who are African American, which is really what's telling us is that individuals in these groups have less complete information in EPIC, and therefore EPIC is not able, or our system is not able to capture those individuals, because for all we know, the differences in terms of criteria should not be there. When we look at payer status, we also have the many more patients, 58% versus 50%, where commercial patients picked up in the registry, and many less patients who have Medicaid were picked up by the registry. So again, speaking about having less complete information about these individuals, which results in being less often selected. But there's some good data and more rewarding data in this slide here, which is comparing the previously identified individuals, individuals who are already been seen, and the ones who were newly identified and had not been seen yet. And here we see that there are less females, so we're able to identify more males, which we really want. But also look at this, we do identify more Hispanic patients through the new system. We do identify more African-American patients through this system too. Therefore, we had not identified those. They had not been seen before. They were missed. And less commercial insurance patients, more Medicaid patients. So really, even though the data is telling us that we have less complete data on some of these groups, at the end of the day, the system is able actually to come up and pick them up, and which turns out to be in a disproportionate way favoring them, which is really rewarding on our side. And what are the criteria that really stand out here from the previously identified to the newly identified? Well, we see many more being identified through both personal and family history. But what we really see a big jump here in the newly identified system is when it's based only on family history. So what's really one of the biggest aspects is that we are identifying many people through family history that's already in the EMR, but we have happily ignored it, or basically we've not been able to identify them just again, even though that the family history is already in the EMR. And of course, we're missing many more that don't have that information. But even among the people who have the information, we are mostly failing to really identify people who do qualify for testing because of that. So in summary, most individuals who qualify for testing through Lynch syndrome and other cancer syndromes are really not being identified. And definitely we need approaches to overcome this limitation. And leveraging information already in the EHR can help identify a high number of candidates. And as we saw, in a disproportionate positive way, affecting among, with a disproportionate positive effect among minorities. And we do need robust systems to really identify more individuals and also make sure that they do testing. And we do need to develop, of course, more strategies to improve cascade testing. So all these individuals we're identifying, their positive effect is amplified just because we are able to identify, to test family members, identify more individuals. Finally, just a little bit of summary. It does take a village to put this together. And I think it's rewarding, and I think it has a lot of capacity to do, it allows us to do a lot of good things, but it's really through the amount of work from people in health informatics and IT, people in cancer genetics and the Lynch syndrome clinic, the pathology department, genetics. It's really, it does take a group of people working together with a shared goal and to really put this to work. But anyways, we're happy that now that we have a robust system identification, we're already in the outreach mode, and we put together already the system to reach out. And I think I'll share all that strategy in another occasion. Thank you very much.